Well, good morning, everybody. Thank you very much for joining us today for this session. We're going to be talking about supporting patients with alcohol and other drug problems in primary care. I'm Sandy Vincent from the education team, and before we begin, I would like to acknowledge the traditional custodians of the lands that we all live and work on. I'm on Dark and Jung land and pay my respects to elders past, present, and emerging. In the session, a couple of things to remind you that we are recording this session. If you have any questions, please feel free to pop them into the chat, but there will be time for you to ask questions directly at the end. And I'll also be putting an evaluation into the chat at the end of the session. It's my very great pleasure to introduce today's speakers. Dr. Chris Homewood is an addiction medicine specialist from Adelaide. His main professional interest is helping GPs and hospital-based doctors to work with people with substance use problems. Dr. Matt Stevens is a senior researcher at the University of Adelaide in Flinders. Matt's research is focused on improving health outcomes for patients with behavioural and substance-based addiction medicine disorders. And Dr. David Outridge is the Associate Head of Department for our local drug and alcohol service here at the Central Coastal Health District. So thank you very much. I'm going to hand over to Chris first to start the session.
All right. Well, thanks very much, Sandy. I'll just start. Can you can see the PowerPoint?
Yes.
Yeah, okay.
Thank you.
Right. So the aims for today are to hopefully you'll be able to understand prescription and illicit opioid dependence a little bit better. Understand prescribing and dispensing strategies that controlling, use of prescription. I mean, it's not only opioids, but benzodiazepines and other medications that are potentially overused. So some prescribing dispensing strategies to sort of try to keep that under control. Understand the role of buprenorphine in managing people with opioid dependence. And then I'll go over some of the administrative tasks when a patient is already stabilised through the local drug and alcohol service and they're on injectable buprenorphine, what sort of tasks you need to go through when you're transferring patients with that to your care, and then some common scenarios, and then finally know when and where to obtain advice. So hopefully we'll be able to knock that all off in the time allocated. So better get going, I guess. So the origins of opioid dependence. In Australia, about 80% of people who are on opioid dependence treatment are there because of illicit opioids, mostly heroin, but a little bit more of the fentanyls and nitazines, which you've probably heard about. But they haven't emerged like they have in North America. So, at this stage anyway. So anyway, mostly heroin, 80%. And prescription opioids. So, I mean, to be honest, the iatrogenic opioid dependence accounts for about 20% of people in opioid dependence treatment. So 80%, 20%, and the risk of becoming dependent if you're prescribed opioids for chronic non-malignant pain, it varies, but it's probably around 10%. So it's just something to bear in mind as to one of the downsides of prescribing opioids longer term. Okay. The efficacy of opioid therapy in chronic pain. I mean, I think probably you're all aware of this now, but evidence of longer term opioid treatment of chronic pain is unclear. The average reduction in chronic, if you use a visual analog scale, drop from 7 down to 5, that sort of level out of 10. So it's a 20 or 30% drop. More useful in nociceptive than neuropathic pain. So neuropathic pains are sort of an entity in its own right, and opioids are not as useful for that. And interestingly, really, there's been no long-term efficacy studies for opioid therapy in chronic pain. So, but despite all of this, shame on us all, really. Chronic opioid therapy increased a lot. So, went up by a factor of 5 up until mid-2010s, the teens. But significantly, it's now declining. And that's probably due to better guidelines and I think just better care and better knowledge about the downsides of chronic opioid therapy. So the risks associated with opioids are essentially three, really. Opioid dependence, a 10% risk, 5-10%, 1 in 10, 1 in 20. Toxicity and deaths, so especially in combo with benzodiazepines, alcohol, and gabapentinoids. And finally, hyperalgesia, which is this sort of scenario where opioids, if they're used repeatedly over a period of time, result in the body compensating for the reduction in pain perception by actually becoming hyperalgesic, so increased pain perception. Just going back to the deaths, you can see here, this is metro, and this is outside capital city. So you can see here the dark blue lines, heroin, it's been creeping up. These ones here are prescription opioids, essentially. They started to drop off around mid-teens, 2015, 16. Methadone's gone up a little bit, and is synthetic opioids. So these are the fentanyl, pethidine, tramadol, tapentadol. Those sorts of things have gone up significantly. And you can see here, city and country, risks of opioid-related death, pretty much the same, but the pattern's a bit different. So more prescription opioids as a proportion of total deaths, less heroin, because you're outside the main supply chain. So it is highly variable. So no two regions are really the same, interestingly, and the factors that contribute to people's opioid use are different from spot to spot. Again, so this is total number of deaths, and this is a big US study which looked at Veterans Affairs. So it's got an N of 155,000. That's the biggest N I've ever seen in anything, really. And what it does there is it looks at relative risk of opioid toxicity death against daily dose. And you can see that, if 1 to 19 milligrams of oral morphine equivalent is 1, that's the reference point, and 20 to 49 goes up by about 2, 50 to 100 goes up by a factor of 4.5, and above 100 goes up by 7. So, on one level, this looks like a lot of morphine, but on another level, a lot of people are taking that. And so you can see here what the relative risk of death is. And here is a relative risk of death against age, and 18 to 29, young and fit, chronic conditions, very little comorbidities apart from mental health related comorbidities. 1, the rate of death goes down as people get a bit older, interestingly. I guess less drug use. Peaks out at about 40 to 49 and then drops off again as people get older. So interesting. This is the sort of peak, this young group here and this older group here, which is not quite what you'd expect, really. And I suspect that at this stage, you've got people with a lot of the comorbidities are kicking in. And at this age, it's more the impulsivity and the injuries and overdoses. So this is just a sort of diagrammatic representation of opioid-related hyperalgesia. So this is with repeated dosing. So what happens is that when you have your first dose of opioid, fentanyl, heroin, morphine, then you get quite significant analgesia, so pain perception goes down. But then pretty early on, you start to develop tolerance. And you've all seen that with patients. So the actual analgesia effect of opioids drops off really early on, after 1 or 2 doses sometimes, depending on the opioid. People start to get an increased perception of pain, so increased pain sensitivity. And that keeps going as well with time. And then with tolerance, this effect, the analgesia effect, goes down as well. So if you actually sum these all out, early on you get a positive effect on pain perception, and then not too long into chronic pain treatment, it starts to, overall, people get more pain. But they'll often say that they've got, the opioids work well for their pain. And what they're actually experiencing is, as you've got, depending on the particular dosage regime they're on, when the levels drop off pre-dose, so let's say they're on slow-release oxycodone twice a day, towards the trough of their levels, they'll start to experience mild withdrawal. But they don't get the full-blown, piloerection and runny nose, runny eyes, and diarrhea and vomiting. They experience pain. So, so when people are on chronic dosing for pain, often that sort of pain and relief that they experience is actually mild withdrawal, and then their opioids are replaced, their levels go up, and then their pain or their withdrawal actually settles down. So that's the sort of dynamic, really, and it's a very, it's a set of conditions that really you can understand why people have difficulty getting their head around this concept of their opioids not actually helping their pain. I mean, they're helping the withdrawal that they get every 12 or 8 or 12 hours, depending on their dosage regimen. So, just got a brief sort of case here. This isn't, it's based on, it's an amalgam of patients that I've seen or had referred to me in the past. So Matilda's age 40. She's been transferred to Yorketti, her GP. One of your older colleagues in the practice was managing her, but has recently retired. She was involved in a car accident about 10 years ago, sustained a chest wall injury with a flail segment, which was repaired. And she had some fractures of T11 and T12, which are stable. She had no neurological problems. Well, no spinal neurological problems anyway. She experiences ongoing chest wall and back pain. She's been prescribed oxycodone modified release, so 40 milligrams BD and pregabalin, because she gets some sort of intercostal, possibly neuralgic pain as well. And she's been on 300 milligrams BD for the past several years. But you've noticed that in the past 12 or 18 months, she's been attending the prescriptions early, initially every 3 weeks, but the past 12 months, even every 15 or 16 days. So she attends one day to the clinic, so she's unbooked, and she tells the front staff that she needs new prescriptions, saying she's run out of her medications. And the last time they were issued was only 2 weeks ago. So I guess the question is, how might you respond? If you like, if you can put your responses in the chat, I'll give you maybe a minute. So at it, and then we can have a bit of a chat about what the options are for Matilda.
You are able to, your microphones, you can unmute your microphones as well if you want to.
Yeah, if you want to just chirp in, that's fine as well. Yep, that's option one. Tell her she's not welcome at the practice any longer. We'll talk through what the pros and cons of these are in a sec. All right, well, everyone's a bit shy. So what I'll do is I'll go through to, consider long-acting opioids. So it's, I think it's a matter of looking at what she's taking and then working out some of the pharmacokinetics of what she's having, and then seeing whether you could modify that. I'll move on. So I guess option one is to advise Matilda you don't prescribe Schedule 8 medications long term, that she needs to find another GP. Option 2 is to tell Matilda to wait until 4 weeks are up and book an appointment for them. And then option 3 is fit her in a day or two, assess her clinically for indicators of withdrawal, etc. So with option 1, I mean, I think there's certainly stories of this going on in Victoria when the real-time prescription monitoring was introduced. And one of the risks associated with this is that people will destabilise mental health wise and become suicidal. So there are certainly risks associated with that. The risk also is because she will go into opioid withdrawal if she's not already in withdrawal. I mean, the benefits are that it certainly it shifts the responsibility away from you, so you don't have to worry about having to manage Matilda. But the other risk, I guess, the other downside is that she'll go off and find another prescriber who will just continue on with this situation. So that's, I guess there's always a sort of balance of judgment about this as to what the best thing to do is. You can actually manage her yourself. But anyway, I'll get on to option 2, is to tell Matilda to wait until 4 weeks and to book an appointment for them. So the risk to that is, I mean, she's 2 weeks out. She'll probably go into withdrawal. She's probably in withdrawal at the moment, and so similar sort of risks to option 1 in a way. The benefits are that she may still engage, she may still stay with you, and what it does do is it sort of outlines some of the boundaries that you're expecting her to adhere to in the future with a different prescriber. So, I mean, there are some benefits from that, but I think the risks are still considerable. So, if you just say, well, I'm not going to, I think at this stage, you haven't had much to do with Matilda, and my view would be that it's probably a bit premature to do either of these, really. So, I mean, you've got a person in crisis, and there are ways you can tighten things up so that you can safely continue to manage her, or at least you can get a bit more time to sort out what's going on. So option 3 is fit her in a couple of days. You're going to need a long consult, probably a double appointment. Assess her looking for indicators of withdrawal or intoxication. Take a more detailed history, sort out exactly when and how much she's taking. So, is she what time of the day is she taking it? And is that because of pain, or is it because she's stressed out and she wants relief from anxiety or whatever? So work out the reason she's having it and the timing. Have a look at SafeScript, so it'll give you an idea about whether she's getting medications from anybody else or not, and also total medications that have been dispensed. Review all her medications and her comorbidities, and just review the risks. So, she had particular risk from drug toxicity, driving, or other substances, particularly other sedative substances like alcohol. All right. There was something slipping my mind. Anyway, I'll get to it later. All right, so they're your options, and so let's go with option 3 for now. But I can understand why people might want to entertain option 1 and 2, but there are significant risks with that. If she can't access that her medications, next thing you know, she'll end up she'll end up in the emergency department with a referral to mental health, possibly to drug and alcohol, but more likely mental health and then drug and alcohol. That's sort of the way things go. So Matilda, so you're going to see her the next day. She's a little, so in terms of just general observation, she's a little restless, sweaty, BP's up, pulses, normal up a little bit, pupils are 4 or 5 millimeters. And when you ask her, she's not taken any oxycodone for 36 hours. So you'd be experiencing even slow release oxycodone experience. You'd be expecting her to be in withdrawal by now. She's certainly not drowsy. She's fully oriented, a little anxious, and at times tearful. So, and just by way of general obs, she's 164 centimeters tall and she's 90 kilos. So she's carrying a fair bit of weight as well. All right. So it turns out when you explore her medication use, she's taking her oxycodone 3 times a day rather than twice. And what was happening was that she was finding that she was waking up early hours of each morning for pain. And so her daily consumption was actually 120 milligrams per day. So this is a frequent phenomenon with modified release oxycodone. It doesn't last 12 hours. It lasts about 8 hours. So if people take their slow release oxycodone at 9 o'clock at night, 9 a.m., 9 p.m. or 8 a.m., 8 p.m., then what you find is it actually runs out in the middle of the night. So their levels drop off. So really the modified release oxycodone should be prescribed TDS really because of that. So her daily consumption's at least 120 milligrams, and she goes up to 4 tablets a day, a couple of days a week. So, but when you look back in detail, the pregabalin's been staying at 2 tablets a day. So she hasn't escalated the pregabalin, but because of the pharmacokinetics of the slow release oxycodone she's taking, she's ended up going up in her dose. So her other medications are mirtazapine, metformin for type 2 diabetes. She's got a bit of gastroesophageal reflux, omeprazole, and some ramipril for a BP. So she doesn't drink alcohol, but she does use a little bit of cannabis. So she has 2 or 3 cones at night to sleep, and occasionally, not very often, sometimes more in the morning to help with the pain. And she doesn't have a car. So from a risk perspective, you're not worried about her driving. Combination of cannabis and opioids. While cannabis is a sedative, it doesn't seem to have that respiratory suppressive effect of benzodiazepines and gabapentinoids and alcohol. So it's not as much a risk with opioids as those other substances, but it can, because it has an effect on the cerebellum, it can affect balance. And so, if you're intoxicated with opioid plus the cannabis, it could make your prospect of falls and injuries more. Okay. So question now, what's her actual, let's assume that she's having 3 a day. So she's using medications over 3 weeks rather than 2 weeks. What's her actual oxycodone consumption? And what's this in terms of oral morphine equivalent? And what might you do from here if you're going to keep on with her management? We know what the risks are. They're overdose, primarily hyperalgesia, which is not making her pain worse at the moment. So just have a think and maybe write down. I mean, do it in chat if you like. What her actual oxycodone consumption is. So she was on 40 BD, but she's using it up over 3 weeks rather than 4. All right. So her actual oxycodone consumption is probably 120 milligrams, isn't it? And that's a lot of oxycodone. If you convert it to morphine, oxycodone's probably about, the conversion rate's probably 2 to 3. So it's probably the equivalent. So 120 of oxycodone is about 180 milligrams of oral morphine. So that's a lot. And the risks are overdose, hyperalgesia, and frank dependence, if you like, or addiction. And what might you do from here? Well, we'll get onto that now. So if you have a look at the Pain Management Network site, which I'd recommend you all have as a sort of a link on your homepage or something, they're recommending keeping oral morphine equivalent doses down to less than 40 milligrams a day, which is, quite low. So the Pain Management Network used to be through Hunter New England, but got appropriated by the Centre for Clinical Excellence in the Department of Health. So, but if you just Google or whatever your search engine is, Pain Management Network, opioids, and you'll get to this. And it's a great site with lots of resources that I'll refer to in a tick. So possible signs of loss of control over use of opioids, or if you like, increasing dependence. It's not a black and white issue. There are at least 50 shades of grey here. So dose escalation, request for early prescriptions, that's sort of the same thing. Obtaining medications from multiple prescribers is a sign that something's going on. Obviously, if someone's altering prescriptions, if there are sedation presentations, ED clinics, road accidents, if they're turning up to your practice intoxicated, that's a flag. And loss of function is the key thing, really. So the opioid use is actually taking over other aspects of their life. So I think that's probably encapsulates what the concept of dependence, and depending on the particular substance, it's this sort of decreasing control over the use of the opioid, and the use of the opioid is taking over other aspects of their lives. Okay, so with Matilda, it's probably just these two here. Okay, interestingly, obtaining, everyone thinks that it's doctor shoppers who have the have the most risk, but there was a really interesting study that looked at deaths. It was done by the coroner in Victoria and looked at opioid-related deaths, and most of them were opioid-related deaths. Most of them are from prescription opioids, as I mentioned before. But in Australia, about 60% or more, and nearly all of those deaths, which were from prescription opioids, there was just one prescriber. Okay, so multiple prescribers is unusual, but if you look on SafeScript, what you might see is that there are several prescribers, but they're in the one practice, and that sets up a bit of a problem, which I'll mention in a minute, in terms of how you respond to this. So, but these are the things that make me, these ones here can occur because of the pharmacokinetics of the medication, increasing tolerance, and there are ways that you can manage this so that it doesn't get out of control. These ones here, a bit more of a worry, and obviously, people are tampering with scripts and sedation presentations and stuff. They're sort of harms, if you like, associated with the opioid use, so more worries then. So how to respond, how are we going for time? Okay, good. So review use, so we've done that, past and present, SafeScript, discuss it with the patient, timing of doses, how taken, symptoms, cognitions as well. Discuss their function, so work out, what's it like, how they're sleeping, when they get out of bed in the morning, can they get up, can they get to the toilet, can they put their clothes on, can they make the bed, just all this stuff, going through a sort of typical day, if you like, can be quite useful. Normal expected activities, what's it like? So that's useful from a pain perspective. Ask yourself whether there's a different disease process going on to explain the escalating doses. So, don't forget, particularly in the intravenous drug using group of people, they the rates of physical comorbidities are really quite high. So, don't assume that back pain is just someone trying to seek additional analgesics, particularly in the injecting drug use group. They might well have an epidural abscess or sort of spinal osteomyelitis or, some other infective disaster going on. So just ask yourself that at the same time. Review all their medications. Control dispensing is really quite helpful in these patients. So someone like Matilda, weekly, twice weekly, or even daily dispensing, single pharmacy, increase your monitoring. So see them more regularly, no early scripts, make sure they understand that. Direct them to some resources around non-pharmacological approaches to pain and encourage them to get active, so get to know them, have a talk with them about ways that they can become more active. And some of them are sort of what we call kinesiophobic. So they're so worried about their pain, and people have told them that if they get pain, they should rest. Then really try to break that belief system down and get them to get more activated. So I think the other thing here is if you're in a multi-doctor practice, make sure that there's just one principal prescriber and that nobody else prescribes for the person unless the principal prescriber is away on leave. All right, not when they're unavailable. It's if they're away on leave, then they need to delegate to someone who'll put their hand up and offer to help. So one single prescriber with a care plan is really important in this. So I've been involved in, instances over the years with the medical board where, medication just gradually escalated and nobody took responsibility in the practice for sort of totally managing the situation. And in some ways, it was nobody's fault, but it was everybody's fault, So anyway, single prescriber unless away on leave, and delegated when they're on leave is another thing to add to that. So chronic pain services, you won't get them in to see most chronic pain services. They probably, when you look at how many people there are with chronic pain, you'd be lucky if you get 5 or 10% of those in to a chronic pain service. And generally these days, they'll just recommend minimizing opioids. They'll recommend non-pharmacological approaches, so pain education, mindfulness, CBT approaches, activity-focused physio and rehab and group work. And of course, all of this is limited in the public system. So in some ways you're stuck. So, you can try a chronic pain service, but, it's going to take 18, 24 months to get in probably. The next thing is around deprescribing, because, someone like Matilda, she's ended up being on, sorry, I'm flicking around here. She's on 120 milligrams of oxycodone, and that's a lot of opioid in anyone's parlance. But you would want to gradually work with her to get her dose down, and but particularly if you're not achieving therapeutic aims. So if she's just down a rabbit hole and stuck, then you have to try to talk her through this concept of hyperalgesia. And of course, everyone panics because they know that you're going to talk about cutting the dose down. But what I'll say down here is that it's a gradual dose reduction is the most important thing, and it doesn't have to be you're not in a hurry. So 5% a fortnight or a month, this could be a 12 or 24-month project. So of course, if they're experiencing severe side effects, overdose needing paramedics or ED or emergency care, it would make you much more, you'd be much more zealous about slowly reducing the dose. Taking benzodiazepines, gabapentinoids, if they're consuming alcohol, you'd be considering deprescribing. But if they're frankly dependent, so if they're injecting, regular prescription shopping, past history of dependence, severe loss of function, then you'd be referring them to your local drug and alcohol service, okay, for opioid replacement therapy. So explain it to the patient, try to gain agreement, gradual, e.g. 5% per month. regular monitoring, especially mental state. Aim for 40 to 60 oral morphine equivalent daily, which is, you know, um, 30 to 40 milligrams of oxycodone, and recommend other sources online. So this was hopefully Sandy will be able to distribute this. It's actually got some links to the particular site here. So there's a lot of interesting resources on this in this page on the network that you can refer people to. Okay, so have a look through them yourselves, have a look at them, and I think you'll agree that they'll actually be quite useful. So, you know, get onto that. Now, this is it's a flow diagram for future reference would be my attitude. But the thing is, if you're prescribing opioids, you need to review these things on a regular basis. So what level of analgesia are they doing? What's the level of activity? What adverse effects are they having? Is there any aberrant use? And what's their mental state like? Because, people with chronic pain have often got mental health problems at the same time. And particularly if you're tapering slowly, then you need to monitor people's mental health and hold the taper if there's significant deterioration in mental state. Okay, so there's no huge hurry. Give them a rest and then recommence in a month. And of course, down here, these are the things that opioid dependence prescribing for opioid substitution would be. So difficulty reducing despite negative consequences, persistent dose escalation, injecting, script tampering, poor level of functioning, and overdose might make you switch to a different strategy. But not everybody can. I mean, you can get doses down, but probably, maybe half of people you won't get off opioids. It's just a legacy that we're going to have to tolerate, I guess. But you can actually do it relatively safely without precipitating a mental health crisis for them. So opiate withdrawal, we sort of preempted before, increased blood pressure, heart rate, sweaty, classical things of piloerection, runny nose, runny eyes, dilated pupils. Remember, Matilda had 4 to 5 millimeter pupils, so 4 millimeters is the sort of magic number. So 4 or more is possibly withdrawal. But younger people have more dilated pupils than older. If you ever look at your kids or young adult kids, they've all got big pupils, and they're not taking meth, and they're not in opioid withdrawal. They just have big pupils. So increased pain is also another thing that people see with withdrawal, and agitation, poor sleep. They feel crap, dysphoria, and diarrhea and abdominal cramps, nausea and vomiting. The sort of train spotting withdrawal that you're probably all familiar with. So this is the life of a regular dependent user. They go between intoxication and withdrawal, restlessness, feeling pretty awful, feeling like they're going to die. And you can see if this happens several times a day, you're going to get pretty quickly conditioned to even small early symptoms of withdrawal. The trouble with regular dependent use, I'll come to that in a sec. So that's what you're dealing with. Opioid substitution. So this is in the sort of sharp end of opioid dependence, where there's a lot of loss of function, and basically the whole life revolves around using opioids. We know that opioid substitution reduces heroin use, reduces mortality, reduces HIV transmission, reduces criminality, and engages the patient, allows other health and social conditions to be addressed. So in general practice, it sort of hooks people in, and you can actually do some good stuff with their primary care. In pharmaceutical opioid dependence, it allows more structured treatment, reduces misuse, easier monitoring because you're actually, people are either on methadone or buprenorphine. And methadone and buprenorphine are both effective analgesics. So you can just substitute one for, if people have been on oxycodone or tapentadol or whatever. So classification of opioids is this, most of them are full agonists. Buprenorphine is a partial agonist, if you like, so it binds the receptor really tightly, but the level of mu activity is less. So it has a sort of plateau effect on pain relief, but it's still a significant in most doses that you use. It's actually significant analgesic, but you get less of the respiratory depression and cardiorespiratory problems associated with buprenorphine. So it's a safer drug. So if you look at, methadone or morphine or whatever just goes into the receptor and then it has a significant effect in its own right. Buprenorphine binds the receptor tightly, not so much agonist effect, but still some. And naltrexone, which is you'd be aware of, we use for alcohol anti-relapse treatment. It just binds the receptor, doesn't have any intrinsic opioid agonist action. So that's sort of the spectrum, if you like. And buprenorphine, how does it work? Well, it binds the receptor so tightly that most opioids that people take won't have any effect. So they just bounce off, essentially. You can overcome buprenorphine if you've got enough money to pay for enough heroin, but usually, both methadone and buprenorphine price people out of the market, essentially. So they just can't afford enough opioid to actually have an effect because of the blocking effect of the buprenorphine and the tolerance that the methadone has induced. So getting back to regular dependent use, up and down, feeling awful, feeling intoxicated, but with regular use, there's less euphoria and less, feeling out of it. Most people, they go through this sort of cycle of withdrawal, which is just as severe, maybe even more severe with time. But they just want to take a drug to get back to feeling sort of normal. Okay. So there's a sort of variation between that and that, but essentially a lot of people function at this sort of level. They just haven't. So it's a pretty miserable life. So when we put people on opiate substitution treatment, they don't get this much fluctuation. So with methadone, it sort of goes up and down a little bit more because it's daily. Buprenorphine, it goes up and down daily as well, but sort of less of an effect. So there's just from that to that to that. And that's why it's essentially why it works. People feel a lot better, ups and downs, and yeah. I mean, the other thing about the agonists like buprenorphine and methadone is that it's because they have some intrinsic action of their own, it stops people from craving. So essentially they stay in treatment, and then you can deal with all the other things like, how to deal with the crises and the stresses and the mental health problems and everything else that they have to deal with on a day-to-day basis. All right, so but comes in a few formulations. So Temgesic, which some of you might be familiar with, 200 mics, non-PBS for analgesia. Subutex just on its own, buprenorphine, 400 to an 8, and then Suboxone comes in combination. So it's a combination of naloxone and buprenorphine. And then there's these long-acting injectables, and there's a couple. So there's one called Sublocade, which is monthly, and there's Buvidal, which is weekly and monthly. All right. So Buvidal's a bit more flexible, but Sublocade's got some good features as well. So, and then breaking down these ones here to this, so you can see the weekly comes in various doses and the monthly as well. Sublocade comes in a couple. So it's given subcutaneously, not IM or IV. And the important thing is that it's never to be given to the patient for transport or storage. So it's got to be a sort of point of care, if you like. So either the pharmacist can administer it subcut, or you or your practice nurse can do it under supervision. Buvidal gets stored at room temp, Sublocade stored at cooler temperature, but it can be kept at room temperature for up to 12 weeks and can be administered by a medical professional, as I said, or a pharmacist or a registered nurse. So if you want advice and support, then there are 3 sources in New South Wales. So probably Central Coast Drug and Alcohol Service, and David can talk about that in a tick. And you've got your Drug and Alcohol Specialist Advisory Service, DASIS, which is a 24/7 whole of New South Wales telephone advisory service. And finally, you got Pharmaceutical Services Unit, which you can access 24/7 via SafeScript, but obviously the feedback is going to be a little bit limited, or you can give them a ring. So if you want a more of a conversation with them rather than a sort of truncated set of emails or whatever, then contact them by phone. But David, do you want to say anything about your local advice?
Yeah, thank you for that. Yes, that's that number you can ring any time and be put through to either our CL nurses or a doctor on call. And we're happy to give advice anytime. We'd much prefer to get a phone call than people just get exited from surgery and end up in ED or just which we have seen sometimes. But that's our number. We can also provide you with our the phone number for our CL nurse. Adana is our CL nurse. She's our GP liaison nurse, I'm sorry, and she's online too. Adana, how would you like to be contacted?
I do. Sorry, my camera doesn't work. It's not coming up. I do have a phone number. I usually go around to the GPs and leave an introduction to a drug and alcohol team. I leave a pack with the GPs, which a lot of the GPs have got. Can you hear me?
Yes, we can.
Yeah.
Oh, yeah. But other than that, generally through the mobile number, which I can put in the chat, and I don't know if I can copy this introductory page and put in the chat. I'm not that advanced. I'll see if I can. Oh, didn't come out very clearly.
Adana, I was wondering is this information in the Health Pathways site as well? Because that's always a good resource for Health Pathways. I think possibly the number is, the phone number is.
The GPLO phone number.
I'm not sure about the GPL phone number, but it's something that we can definitely add into the Health Pathways. So I've put a link there, but
That's
again,
great.
I will put, there will be access to these slides for anyone who's attended this.
Oh, great. Okay.
Yeah, thank you. Yes, Chris, that was very good, particularly because you addressed some of the hard questions, or the elephants in the room that we don't talk about, is the difficulty with chronic pain services and the fact that GPs often are just unable to access those services, and as you say, in the end, they tend to, besides the psychosocial and physical reactivation, their approach is deprescribing, and we know that many patients just will not have success in that pathway. So appreciate the very practical talk. We are getting a number of people referred for assessment of opioid dependence by GPs, and I guess it's a degree of reassurance is needed by people who are out there prescribing opioids long term and knowing whether they're within the bounds of a manageable situation, or whether they need to refer on to us for opioid maintenance treatment or substitution treatment. And this is where I think a phone call or contact with us would be good, and that way we can sort of guide you onto techniques, as Chris has mentioned, such as stage supply and that sort of thing. But when there's a case where there's obviously, as Chris said, loss of function and some scary things happening like car accidents and overdoses, then we're happy to be called and act very quickly. And we don't have a waiting list essentially for opiate treatment program enrollees, and particularly if someone like a GP calls us, we will facilitate that within days. So don't hesitate to call us when there's something like that. But at the other end of the spectrum, where people are having trouble just presenting early and escalating doses, then we can often just offer advice and just take them a bit less urgently. But,
All
right. So
thanks,
yeah.
mate. I was just reminded me. I think with SafeScript and then with all, there was that whole bunch of letters that came out from the Commonwealth Department of Health for people who were prescribing a lot of opioids. Regardless of whether they were doing palliative care or geriatric care, or so those sorts of important parts of general practice that obviously would skew your prescribing performance data. So I think a combination of things has made GPs much more sort of anxious about the medico-legal aspects of what they're doing, and I think if you're prescribing opioids for chronic non-malignant pain, if patients are turning up on a regular basis, if you're exploring those 5 A's, how much analgesia are they having, how much activity are they involved in, are they having any adverse consequences, those sorts of things, and just sort of tapping into how their mental health's going, and you're keeping things under wraps, and there's one pharmacy and there's no sign of dose escalation, and maybe you're trying to get their dose down. No one is going to be critical of you for that. You don't actually even need, a special, a pain specialist or a drug and alcohol specialist sort of backup, if you like, for that. If you're doing those things, you can rest assured, most patients are in this situation through probably, no fault of their own really. And like 15, 20 years ago, the view was, well, you give them as much opioid as they need to control their pain. I mean, that was the message we were getting from pain units. So, and what we're dealing with now is the legacy of that. So I think, don't be frightened. The regulators aren't, they're not out there to get you. It's just if you're dealing with this in a sort of reasonably evidence-based manner, we know that you can't deprescribe everybody off, because a lot of patients decompensate and become unstable, and it's the last thing you want, So don't be too anxious about it. You don't if it's moderate levels of opioid use, then it's not ideal, but it's something you just you can manage safely. I've just got a couple of more slides, and I think that's probably.
Oh, sorry. Yeah, go ahead.
No, that's all right. I might not have. Hang on. Oh, yeah. So if let's say you're receiving somebody from the public treatment service, and the things you need to do really is just you've got to obtain an authority from the pharmaceutical services unit via SafeScript. But the things you need to do is establish their dose, frequency, and date of last dose, and obtain a health summary from current treatment service, and establish current medication. So, with a good ISBAR transfer of care, you should get all of that on a platter. Okay, so the only thing you need to do is work out, get an authority, and work out when the next dose is due. Really, so prescriptions are now PBS. Depots can't be given to the patient for transport or self-management, and as I said, can be administered by GP, nurse, or pharmacist, and they can be written by any prescriber, so a medical practitioner or a nurse practitioner. And you can see there's a link to the guidelines. So if I've got enough time, but anyway, I've got 5 more minutes. So these are 3 common scenarios. So Pam's been on Buvidal 128 for the past 2 months. She was transferred to a GP a month ago. She presents 22 days after her last dose, experiencing mild opioid withdrawal, anxiety and restlessness mostly. Examination's largely normal. Pupils are 3, pulse is okay, no tremor, no sweatiness, looks comfortable. And Pam was previously a pretty heavy heroin user, $500 a day. So that's a lot of heroin, even in Sydney. So what options have you got for her? Well, just because of time, you've got a couple of options. One would be to give her a dose early, and maybe she needs a three weekly regimen, 22 days or whatever. So you can give it between 20, 21, 22 days and 35 days. Alternatively, you could put her dose up to 160. Okay, so, and if she had a 5-star heroin dependence, then she may need more Buvidal than that even. So 160 is the maximum for Buvidal. The next one is so that's an early presentation. This is a late. Tom's been on Sublocade 100 milligrams monthly the past 4 months, and before that he'd been on 300. So normally with Sublocade you load them up for a couple of months with 300 monthly, and then you switch over to 100 for maintenance. And he's late for his dose. It's 42 days or 6 weeks since he. So he's technically speaking, he's actually inside the window. So with Sublocade, you can give it anywhere between 26 days and 42 days. Okay, so with Tom, just give him his Sublocade. That's fine. Okay. Nigel. So this is something that we really didn't understand or didn't really know. All the emphasis was on getting people onto depot, but really, how to get off depot. So Nigel's so this sort of scenario used to be a complete, I don't know a polite way of saying it, but it used to be a real headache. So he was a plumber, age 38. He's been on Buvidal monthly for the past 3 years. So he's got a new job in Arnhem Land. All right, so there's no prescribers up there, and anyway, like there's probably only one chemist every 500 kilometres. So he's been well on the Buvidal, no additional opioids, no stimulants, no alcohol. So he's been great. Occasional cannabis, maybe once a week. He wants to come off. So how might you advise him? Well, he can probably just come off. So what you find is that with the depot, that it's not, if you look at the plasma levels of the buprenorphine, it's not a square wave. They actually flatten off for anywhere up to sort of 35 days, and then there's a slow taper off which occurs. It's not quick. It can go for another month or so. So in fact, if you use objective measures of withdrawal, we use a thing called a COWS score. If you actually do COWS on people, like Nigel after their Buvidal's run out, their COWS scores are all 0 or 1, all right, or 2. They might feel a bit uncomfortable from time to time, but they don't have any significant withdrawal. So with Nigel, unlike when they were on methadone or buprenorphine sublingual, he can just go up there, and he won't experience much withdrawal. But like it's Northern Australia, and they drink like fish. So you need to have a bit of a chat with him about, maybe he won't be on opioids anymore, but he might run into problems if he starts drinking alcohol, and it's the last thing you want. Because in contrast to opioids, alcohol is a complete total body toxin. So you don't want him developing an alcohol dependence. So you'd counsel him about that as well. Okay. Now there's on your New South Wales Health site. So this has got links. So there's a brief guide to depot, and there's a long guide. So I presume you want this one, but if you want a bit of background information, it's a bit like the NH and MRC guidelines on alcohol use. There's a short version, and then there's a 500 pages. So this one's got all the information you might want in it, and you can always give David or Adana's crew a ring for some extra advice. And when to seek advice, I think if there've been hospital, ambulance admissions, behavioural problems that don't settle, emerging complex pain problems, if they've got alcohol dependence that you've become aware of, if they turn up and they're intoxicated, or if despite the depot use there's regular daily heroin use on top of that, and you're not achieving the therapeutic aim. So they're the things they'd be the triggers that would make you want some help. And these are the numbers to call. Okay, so or have a look on Central Coast Health Pathways. It's the other place if you've got that on your screen shortcuts. So look, we're just on 1 o'clock. So I was sorry, I dragged the chain a little bit. There's a lot to cover.
30 over here, Chris.
If everybody's just goofing off now, of course, it's time to go back to work. Well, that's fine. But if you've got any questions, put them on the chat or just turn your microphone on, and I'm happy to have a bit of a talk.
Absolutely. Thank you, Chris. That was amazing. Thanks very much. I'm happy to hang on. If there's anybody who wants to stay back and ask any questions.
Questions. I might just raise the issue of one of the issues we see is people who are legacy patients on Physeptone tablets for pain, and it's on our in-state. It's on this. I think it's the B list of opioids that have to have an authority sort. So patients often don't want to stop or change, and it inevitably leads to a monthly review for an authority script. But yeah, the definition of addiction or drug dependence is very vague on the New South Wales Ministry of Health website. It's I think it's something to the effect of those who have an irresistible urge to use opioids due to repeated administration. So it's I think that's changing in the new year. It's going to become a more DSM-5 definition. But if people do go to apply for an opioid, for an approval to prescribe for pain, they may get stymied at that point as well, and have trouble interpreting whether their patient has opioid dependence. But I think what you've done is shown the practical kind of features. But it's just that the Physeptone tablet patients are the ones that a lot of GPs just don't want to prescribe because they have to keep applying every 12 months for an authority.
Yeah.
I don't know if it's the same situation in South Australia, but
well, we've got. I mean, if you're prescribing ongoing opioids for more than 3 months for someone with chronic non-malignant pain, you got to reapply every 12 months here. So it does vary from state to state, but
yeah, I don't think we're under any obligation to reapply for any opioids for every opioid in any patients that aren't considered dependent. We just have to have it for PBS purposes, a second opinion every 12 months. Any GPs can confirm that? I think, I don't think we have to apply for any chronic non-malignant pain every year, unless we consider them drug dependent. Yeah. So you do have the anomaly where some people are on massive doses of opioids but aren't considered dependent because they just stick within their guidelines and don't have any problems. And so GPs are just prescribing these large doses with a monthly review. But there are some drugs such as buprenorphine, which you do have to have an authority for, not for Norspan, but for Temgesic, unusually. There's
a whole bunch of sort of idiosyncratic historical issues.
All
right, Wilson, I reckon no one else has brought anything up, so we might sign off.
Thank you.
All right.